Hey everyone, welcome back to Scrubs and Notes. I'm Raymond, and today we are taking on one of the most challenging and critical topics in internal medicine and surgery, pancreatitis. This is an inflammatory condition of the pancreas that can have devastating local and systemic consequences. By the end of this video, you'll have a rock-solid understanding of its diverse causes, the deadly cascade of autodigestion, how to classify severity using modern scoring systems, and the crucial management steps for both acute and chronic forms. So let's get our notes ready and dive in. The pancreas is a vital retroperitoneal organ with both exocrine and endocrine functions. Pancreatitis is the inflammation of this organ. It is broadly divided into acute and chronic forms. Let's start with acute pancreatitis. Acute pancreatitis is an acute inflammatory process of the pancreas with variable involvement of regional tissues and remote organ systems. It's a common cause for emergency hospital admission. The two most common causes are gallstones and excessive alcohol consumption, which together account for approximately 80% of cases. The rest of the causes can be remembered with the helpful mnemonic I get smashed: idiopathic, gallstones, ethanol, trauma, steroids, mumps and other infections, autoimmune pancreatitis, scorpion sting, hyperlipidemia, ERCP, and drugs. The pathophysiology of acute pancreatitis is a catastrophic cascade of autodigestion. The central event is the premature conversion of inactive trypsinogen to active trypsin inside the pancreatic acinar cells, which normally only happens in the duodenal lumen. Activated trypsin then activates other pancreatic zymogens. Proelastase is converted to elastase, which digests the elastin in blood vessel walls, leading to hemorrhage. Prophospholipase A2 is converted to phospholipase A2, which digests cell membranes, causing coagulative necrosis and fat necrosis. Procarboxypeptidase is converted to carboxypeptidase, which contributes to proteolysis. The breakdown of fat by lipase releases fatty acids, which then chelate or bind to calcium ions. This process, called saponification, can lead to clinically significant hypocalcemia. The local inflammation releases a massive cytokine storm into the systemic circulation. This triggers a systemic inflammatory response syndrome, which is the direct cause of the life-threatening multi-organ complications of severe pancreatitis. This includes acute respiratory distress syndrome from alveolar capillary leak, acute kidney injury from hypovolemia and renal vasoconstriction, circulatory shock from profound vasodilation and fluid sequestration. The revised Atlanta classification is standard for assessing and describing acute pancreatitis. There is phases of acute pancreatitis, severity, morphological types, and fluid collections. For phases, there is early phase, which is during the first week. It is dominated by the whole systemic inflammatory response and organ failure. Then there is a late phase, which is after the first week and is characterized by persistent systemic signs or the development of local complications. For severity, there is mild acute pancreatitis, which is the absence of both organ failure and local or systemic complications. Moderately severe acute pancreatitis, which is the presence of transient organ failure for less than 48 hours, or the presence of local or systemic complications. Then severe acute pancreatitis, which is defined by the presence of persistent organ failure for more than 48 hours. This is associated with high mortality. For morphological types and fluid collections, there is interstitial edematous pancreatitis and necrotizing pancreatitis. In interstitial edematous pancreatitis, there is diffuse inflammation and swelling of the pancreas. And under this, there is two more, which is acute peripancreatic fluid collection and pancreatic pseudocyst. Acute peripancreatic fluid collection occurs early, less than 4 weeks. It is sterile and has no defined wall. Pancreatic pseudocyst develops later, that is after 4 weeks, and is an encapsulated collection of fluid with a well-defined wall. Then necrotizing pancreatitis is the presence of pancreatic or peripancreatic necrosis. Under this, there is acute necrotic collection that occurs early for less than 4 weeks, contains both fluid and necrotic debris and has no defined wall. Then there is walled-off necrosis that develops later, that is more than or equal to 4 weeks, and is a mature encapsulated collection of necrotic debris. Clinically, the hallmark symptom is severe, constant, boring epigastric pain that often radiates directly to the back. The pain is typically worsened by lying supine and relieved by leaning forward. Nausea and vomiting are also very common. On physical exam, you'll find epigastric tenderness to palpation and often diminished bowel sounds due to an ileus. In severe necrotizing pancreatitis with retroperitoneal hemorrhage, you may rarely see Cullen's sign, that is periumbilical ecchymosis, or Gretna's sign, which is flank ecchymosis. These are very ominous signs of severe disease. The diagnosis of acute pancreatitis requires at least two of the following three criteria: characteristic epigastric abdominal pain, serum amylase and/or lipase levels above or equal to 3 times the upper limit of normal. Lipase is more specific and has a longer half-life, making it the preferred test. Then characteristic findings on cross-sectional imaging, that is CT or MRI. For investigations, the best initial imaging test is an abdominal ultrasound used to look for gallstones or a dilated common bile duct as a potential cause. A contrast-enhanced CT is not required for initial diagnosis. Its primary roles are when the diagnosis is uncertain, in patients who fail to improve after 48 to 72 hours, or to detect and characterize local complications like necrosis and fluid collections. MRCP is also useful to visualize the biliary tree and identify common bile duct stones. Predicting severity early is crucial to triage patients appropriately. There's a number of criteria that are used. We have the SAS criteria, which is the presence of more than or equal to 2 criteria in admission, that is a temperature of less than 36 or above 38 degrees Celsius, a heart rate of above 90, a respiratory rate of above 20, a white blood cell count of less than 4 or above 12, and this is a strong predictor of severe acute pancreatitis. The BSAP score, which is also known as the bedside index of severity, it is a modern simple score calculated within the first 24 hours. 1 point for each of the following: BUN above 25 mg per deciliter, impaired mental status, SARS present, age above 60 years, pleural effusion. A score of above 3 is associated with significantly increased mortality. The Glasgow Emery score, which is another important score that uses 8 parameters that you can remember with the helpful mnemonic pancreas. A score of above or equal to 3 indicates severe acute pancreatitis. C-reactive protein, a level of above 150 mg per liter at 48 hours, is a good indicator of developing pancreatic necrosis. Management of acute pancreatitis is primarily supportive. For management of mild acute pancreatitis, we have fluid resuscitation with aggressive IV crystalloids, analgesia with IV opioids such as morphine, and these are essential for pain control. Nutrition: if pain and nausea resolve quickly, a low-fat oral diet can be started early. There is no need to wait for lipase to normalize. And then treating the cause. If it is caused by gallstones, perform a cholecystectomy during the same hospital admission after recovery to prevent recurrence. For management of severe acute pancreatitis, this requires admission to a high dependency unit or ICU. There is aggressive fluid resuscitation, which is the most important intervention to prevent pancreatic hypoperfusion and organ failure. Use balanced crystalloids such as Ringer's lactate at a high rate, guided by urine output and hemodynamics. For nutritional support, the old paradigm of meal per os is gone. Early enteronutrition within 24 to 72 hours is now the standard. Feeding into the gut maintains the integrity of the gut barrier and reduces the risk of bacterial translocation, which can lead to infected necrosis. Nasojejunal tube feeding is preferred, bypassing the pancreas. Prophylactic antibiotics are not recommended for sterile pancreatitis. Antibiotics are only used if a secondary infection, such as infected necrosis or cholangitis, is suspected or confirmed. In cases of gallstone pancreatitis with concurrent ascending cholangitis, an urgent ERCP with sphincterotomy should be performed within 24 hours. In cases with biliary obstruction but no cholangitis, ERCP is recommended within 72 hours. For management of local complications, infected necrosis, which is the most lethal complication, suspect it in a patient who deteriorates with fever after the first week. The diagnosis is confirmed with CT-guided fine needle aspiration. Management requires broad-spectrum IV antibiotics and removal of the dead tissue. A step-up approach is now favored, starting with less invasive percutaneous or endoscopic drainage before considering open surgery. For pancreatic pseudocysts, asymptomatic pseudocysts can be monitored. If they are large, above 6 cm, persistent above 6 weeks, or cause symptoms, they require drainage via endoscopic, percutaneous, or surgical approaches. Now let's quickly shift gears to chronic pancreatitis. This is a progressive fibroinflammatory disease of the pancreas characterized by irreversible destruction of the exocrine and endocrine parenchyma. The main causes can be remembered by the Tiger O classification, that is toxic metabolic, idiopathic, genetic, autoimmune, recurrent and severe acute pancreatitis, and then obstruction such as tumors or ductal strictures. The clinical presentation of chronic pancreatitis is defined by a triad of symptoms: chronic abdominal pain, which is a dormant symptom, a debilitating epigastric pain that can be constant or intermittent and radiates to the back, which occurs when over 90% of pancreatic function is lost. This leads to steatorrhea, that is foul smelling, greasy stools, and weight loss. Then lastly, endocrine insufficiency, which is caused by the destruction of islet cells that lead to insulin deficiency, a condition known as pancreatogenic diabetes or type 3C. The cornerstone of diagnosis for chronic pancreatitis is imaging. A CT scan is often the best initial test, showing the characteristic triad of pancreatic calcifications, ductal dilation, that is a chain of legs appearance, and glandular atrophy. Fecal elastase 1 is a simple and reliable stool test to diagnose exocrine insufficiency. Low levels are indicative of significant pancreatic damage. Management is multidisciplinary and focuses on symptom control and complication management. Absolute cessation of alcohol and smoking is mandatory to slow disease progression. Pain management is challenging and can involve simple analgesics, neuropathic agents, and even endoscopic or surgical interventions for refractory pain. Exocrine insufficiency can be managed with pancreatic enzyme replacement therapy like Creon, which must be taken with every meal and snack. Endocrine insufficiency requires dietary management and insulin therapy. And that brings us to the end of our deep dive into pancreatitis. We've covered the devastating journey of acute pancreatitis and the long-term progressive nature of the chronic form. This is absolutely vital knowledge for your GI rotation and your final exams. If this video helped you, please that like button, subscribe to Scrubs and Notes for more essential medical content, and let me know in the comments what topic you want to tackle next. Thanks for watching, and I'll see you in the next video.